Okay, good morning, class. So today we're going to start talking about orthopedic physical therapy. Um, we've been talking about the different types of physical therapy, and this is going to be more the musculoskeletal types of injuries and things like that, and not just injuries, but diseases as well. So let me share my screen, and we'll get started. Okay, so I think these will be all the ones that we're going to be covering. Talk about each of these individually. Okay. Well, let me make this bigger. That would help. Okay. Orthopedic physical therapy is treats musculoskeletal disorders. So treats disorders that have to do with bones and muscles mainly. And it is by far the largest PT clinical specialty. Most of the time when people think of physical therapy, occupational therapy, or physical rehab, they think of orthopedic type injuries like shoulder injuries, knee replacements, hip replacements, shoulder surgeries, neck surgeries, back pain, things like that. Those are all orthopedic type physical therapy things. Okay, so what are our general goals in orthopedic practice? Well, we want to maximize and this is not going to be just the goals for just ortho patients, but this is going to be the goals for any type of patient, but these are a little bit more specific for ortho patients. So we want to maximize their function. So we want to be able to get them to be able to function in their daily life at their highest potential despite their impairment or their pain or their injury at the time. We want to help alleviate their pain. So we want to help get rid of some of their pain. We'll work on that next semester. Decrease stress on joints. Ensure proper posture. So posture can cause a lot of different pathologies and musculoskeletal problems later on in life. So, and even as a child. So there are a lot of things that just proper posture work can help. And sometimes we spend a lot of times working on posture with people. And it promotes tissue heal. We promote tissue healing of wounds, range of motion by stretching and flexibility. Okay, so what do you do in an orthopedic exam? Same thing as a regular exam. Patient's history. Let's talk about their observation of the patient. So let's look at we're going to look at their posture, how they're standing. We're going to look at their gait, how they walk. We're going to see if there's any deviations, if there's any asymmetries, things like that. We're going to look at their passive and active movement. So passive and active range of motion. We can take their joints to range of motion, or we can have take measurements, or we can have the patient do certain physical tasks, and we can watch and see how they do them. We can also do manual muscle testing, which is a formal strength test. Other special tests, reflex tests, palpation, and y'all know what palpation means, as y'all are learning that in anatomy right now. That's just feeling bony prominences of muscles and landmarks with your hands on the patient. And evaluation of diagnostic imaging. And that's not something we do. I'm going to let you read through this. With a history, it's going to be obviously their medical history, their past medical history, but you know, are they having pain? Where is their pain? Why are they having pain? What kind of pain is it? Is it sharp? Is it dull? Is it achy? What makes the pain worse? What makes the pain better? What caused the pain in the first place, or the injury in the first place? Was it an injury or was it a disease? And is this something you've had before? Has your family had it before? And what's your lifestyle like? And when we say lifestyle, I'm not talking about personal details of their personal life. I'm talking about, are they a sedentary person? Are they a more active person? Do they tend to be an overweight person, or are they a thin person? What is their nutritional status like? What is their water intake like versus other types of fluids, like sodas and things like that? So let's look into musculoskeletal assessments a little bit more deeply. So we've got posture, and you look at posture from the front and from the sides and from the back, because there's bony landmarks for all those regions we need to be looking at. And they all need to be symmetrical or level. But we'll talk about that next semester in Intro to Kinesiology. Range of motion is how far a joint can be taken through its normal range. So if I'm taking shoulder range of motion, this would be my shoulder going through its normal range of motion. MMT stands for manual muscle testing, and that's a grade of scoring muscle strength that you'll learn in semester 3. Function and ADLs. ADL stands for activities of daily living. Things like getting around and being able to get yourself in and out of bed, being able to get yourself in and out of chairs, being able to walk, be able to dress yourself, being able to eat on your own, being able to cook for yourself, being able to drive yourself. Those are functional things that are called ADLs. Activities of daily living, being able to take care of your own physical self and mental self. DTRs, we would check reflexes with a reflex hammer, and then do a formal gait assessment where we look at their walking in greater detail. So what is a gait assessment? It's just a visual observation of the patient's gait and walking pattern. So gait is made up of, you'll learn this in more detail next semester, it's made up of 2 phases, swing phase and stance phase. And one leg is always going to be in stance phase, and that means it's standing on the ground, and one leg's going to always be in swing phase, which it's swinging forward to take the next step. It's just a very, very, very vague description of gait. What do we do with musculoskeletal and orthopedic type people? Well, we'll do therapeutic exercise, weight training, exercise resistant band training, body weight training, patient education on posture and on proper exercise mechanics. We can use physical agents and modalities to help with pain. So things like hot packs and cold packs and electrical stim units, which we'll learn those next semester. We do things like helping them make their walking better. So we can do gait, we call that gait training, training them to make their walking into a more normal pattern. And then use of orthoses, which are braces, external braces that may go around the leg, and prostheses, which are artificial limbs if you have an amputation. Therapeutic exercise is what I was talking about, with just things to make you stronger. So interventions that use muscle contractions, different body movements, physical activities that can be functional activities just to help build strength. Range of motion exercises are included, and not just strength, like muscle power, but endurance. So overall cardiovascular endurance, muscular endurance, increasing your tolerance to exercise, increasing your coordination and your speed, and things like that. So when we talk about therapeutic exercise in the ortho world, we have to give exercise parameters. So what does that mean? Well, frequency, we got frequency, duration, repetitions, sets, intensity, and mode. Okay, so what do those mean? Well, frequency means how often or do we want to see the person? Okay, so how many times per day if you're working in inpatient, or how many times per week, which is usually the case in most other settings. Duration, how long do we want to see the patient for? Do we want to see them for a month? Do we want to see them for 2 months? Do we want to see them for 6 weeks, 8 weeks, those kind of things? So we could say the frequency could be 2 times a week. The duration could be for 6 weeks. Repetitions. Repetitions means the number of muscle contractions you perform or a number of times you perform one exercise. So if you're performing bicep curls, if you do 5, you've done 5 repetitions. You've repeated it 5 times. Sets means, if I do 5 repetitions of bicep curls, I'm going to rest, and then I'm going to do 5 more repetitions. Well, I'm not going to call that 10 repetitions. I'm going to call that 2 sets of 5 repetitions each, because you rest during a set. Intensity would be the how much weight, how much resistance you're using. And mode could mean whether you're using body weight for your training. It could be mechanical weights, elastic weights, aquatic, things like that. Home HEP stands for home exercise program, and that's what we always give to our patients. Okay, range of motion exercises are just exercises that move a joint through its range of motion. So there's passive range of motion, which is done by just the therapist, so just by you, where you would stretch the person and take their joint through the range. There's active assistive range of motion, AAROM, which is when you and the patient do it together. And then maybe if they're weak and they need help, but they can do it, they just need some help. So you do it together. And then there's active range of motion, which is totally about the patient. So what I'm doing right now is active range of motion on my shoulder. Like I said, passive range of motion is moved by the joint or a mechanical device. If the patient's unable to do it by themselves, or if active range of motion would be contraindicated, maybe it would cause injury to the healing process or something like that. We do passive range of motion to decrease pain and to decrease the prevalence of a joint contracture. And a joint contracture is the permanent shortening of a joint to where you can no longer stretch it out. And that's no bueno. The only thing that can undo a contracture is surgery. Active range of motion is what's actively performed by the patient. I've already said that. So to promote strength, to build coordination, prevent DVTs, deep vein thrombosis, blood clots, increase our circulation, and get ready for functional activities. Active assistive range of motion is when the patient needs help performing the range of motion. So you can see this lady over here on the patient, on the little lady on the, is this the right or the left? The left side of the screen. She's got a shoulder pulley system when she's pulling her shoulders up on a pulley system like that. Well, she's probably just had a shoulder surgery, and she's got one good arm and one bad arm, and she's stretching out, and she's working on stretching her arm and strengthening it through its normal range of motion. But because of limitations in strength and pain after her surgery, she needs a mechanical device to help her. Same thing here with this lady in the middle. She's holding on to a dowel rod, and she's using that to stretch her shoulder. And this lady over here on the last one is using what we call a finger ladder. And that's when, if she needs to work on raising her arm up above her head, but she doesn't have the strength, she can use her fingers to help walk up the ladder. And believe it or not, that actually is enough assistance from your fingers to help you get your hand up above your head. And that's just a way of getting you to work on strengthening overhead until you don't have to use the finger ladder. But these are not by far all of them. You can get creative. You can make your own active assistive range of motion equipment. Anything you can be very, very creative. Lots of things out there on the market that people have made billions of dollars from. Okay, types of exercises to increase strength. We've got isometric, isotonic, and isokinetic. Okay. let's go through those just real quick. Isometric means you tighten up a muscle, but there's no change in the muscle length or the joint doesn't move. So if you're laying on your bed with your knees straight, and then you just tighten up your quads, your thighs, and just make your quads tight, but your knees were already straight, so nothing, your legs didn't move, but your quads are just tight now. You squeeze your butt together, and that nothing happened. You just tightened up your buttock muscles. That's the isometric contraction. It's muscle tension, but no joint movement and no change in the muscle length. Okay, let's skip isotonic for a second. Isokinetic at the bottom. Isokinetic is a dynamic exercise that is only done with specialized machines. So this is done during sports and like heavy, like competitive sports recovery and things like that can only be done with machines. It's when you're going through a concentric contraction in both directions of the range. Let's go back to isotonic. Isotonic is a dynamic concentric or eccentric muscle contraction. So most of our contractions that we perform every day are going to be isometric, they're going to be isometric, concentric, or eccentric. A concentric contraction means that you're lifting something and the muscle is shortening. So think of lifting against gravity. So if I'm doing a bicep curl and I'm holding my iPhone in my arm and I'm doing bicep curls with my iPhone, well, this is a concentric contraction of my biceps because I'm having to lift my phone against gravity. And my bicep muscles are getting shorter. They're shortening and coming together, which is what pulls my arm up. Now, an eccentric contraction would be if I'm letting the phone go very, very, very slowly. Some of you might say, well, your arm is going straight, so it must be your triceps that are straightening your elbow out. But if I'm doing bicep curls in the gym, the proper way to do it is to let your arm go very, very slowly, nice and controlled. That's called an eccentric contraction of the biceps. It's a lengthening contraction. The biceps are controlling that weight of the arm all the way down so that you just don't flop your arm straight down and rip your arm off. That would be no bueno. Okay. Then we also have some other types of, so that might be confusing to you. If it is, I would tell you to do this. Look in your book right now and look, I want you to find the differences between isometric, concentric, and eccentric. Read what the book says, and then I want you to try to maybe look at examples on YouTube. Maybe click on eccentric workout or concentric workout of upper body concentric workout, lower body eccentric workout, and see the types of exercises are going to be. Concentric exercises are shortening, usually against gravity, going up against gravity, and then eccentric are lengthening contractions going with gravity, but controlling it. Okay. Now, we've got these two new terms, closed kinetic chain and open kinetic chain. Well, let's look at the pictures as we describe them. A closed chain exercise is any exercise where the distal end of the body is fixed to a support surface, such as the floor, the wall, a pedal, a force plate, or the ground. So this lady here at top is doing squats. She's doing squats. The support surface, she's strengthening all the muscles in her core, all her legs, all the muscles throughout all her leg groups, and her support surface is the floor. The floor is what she is giving her the resistance along with gravity. That's a closed chain exercise. An open chain exercise is when the distal segment moves freely in space and you're not bearing weight on a support surface. So this guy here swinging is like if we've all sat on a high bench or something and swung our legs back and forth. If your feet don't touch the floor, that's an open kinetic chain activity. So there's no support surface. Another example of, let's see, this is isometric, but I'll say another example of a closed kinetic chain activity would be a standing wall push-up, because now you've got your arms are against the wall. You might be strengthening the arms, and you're standing up, but the wall is your support surface. So that's a closed kinetic chain of the upper extremities. Okay, isometrics are, I've already explained this, is when you tighten your muscles up, but there's no joint movement and there's no muscle length change. So things like doing planks, a lot of Pilates movements, a lot of times will be isometric exercises. A lot of some yoga poses that are held for long periods are isometric exercises. It's just you're holding a certain position with your muscles, but no movement is happening. Here's isotonic, and remember that includes concentric and eccentric. But there's going to be a constant load. So there's going to be a weight that you're using. And here's an isokinetic machine that somebody is using. So they are there, and you can see this guy's leg is wrapped into the arm of the machine. He's got the same amount of resistance going into knee extension as he does into knee flexion. So it's testing his leg in all motions at the same time. And it's also testing its speed too. So it's reserved for later stages of high level rehab, or usually more for athletes. Things that we can do to promote range of motion and relaxation are just stretching exercises. I mean, you know that if you wake up in the morning, most of us will do a quick stretch or so. That feels good. It kind of warms our muscles up and gets us ready to go. Well, it's the same going. Before we work out our patients, we can stretch them a little bit and help get them ready to go. We don't want to overstretch them because then we could cause some muscle overstretching, and then they wouldn't be able to perform as much force. But we do want to give them some stretching so that their muscles can get warmed up and get a little bit more flexible for the activity that we're going to have them doing. Yeah. Usually early on in the stages of rehab, we're doing most of it for them. And then later on, they're self-stretching by themselves. So we teach them how to do stretches along the way. Relaxation exercises, just things that decrease respiratory rate and decrease the blood pressure and decrease the heart rate. Those are things like deep breathing exercises, relaxation exercises like deep breathing, meditation, imagery. We're not mental health therapists, but if you do have any experience if you ever use meditation yourself, or any relaxing yoga breathing exercises, you can use those with your patients too. Make sure we're always going to be educating our patient no matter what type of therapy we're giving them, especially in the ortho world. We need to make sure that we do it in a positive environment so that we're not looking down on them, but looking at them as equals and as peers and saying, hey, I'm giving you all these instructions and I'm telling you to do all these things, but I'm not the boss of you. This is just, I'm giving you the tools to get better because I want to help you get better, but you're ultimately the person that has to do it. But I'm here to be your team coach and cheerleader, and let's do it. Communication is important between you and your patients. If you're not on the same page with the plan of care, if they're not liking the exercises you're choosing, or if you're not liking their performance and they won't take your cues to make it better, I mean, things just aren't going to work out. And then each patient is always going to have special needs. Every patient is always going to be a little bit different, a little bit just depend on their personality or their injury or their pre-morbid status, or maybe they're seeing you for orthopedic injury, but they have Down syndrome too. So they're not cognitively aware enough to make all the decisions for themselves, and maybe they're really distractible, but they still have a good time with you in the gym and they'll exercise. But you have to remind them that you have to kind of rein them in every few minutes to come back to the activity, but you still get them to do the exercises and you get them better. That's how we do it. Physical agents and modalities, we use these a lot in ortho, like I mentioned. These are used things like hot and cold and electricity. This just used to reduce inflammation and edema, help speed the time of soft tissue injuries, decreases pain, remodel scar tissue, and it can help increase tissue length and flexibility. I can't see what this so in the ortho world, general contraindications for a lot of vigorous activity are the very, very young to the very, very old. With pregnancy, you're not going to be able to do a whole lot of vigorous activity, although pregnant women do need to exercise throughout their pregnancy, land-based and water-based exercises. They just need to, they need to they don't need to just determine on their own, okay, I'm going to tone my exercises down a little, but I'm going to keep doing it. They need to meet with either a therapist, one of us, or a fitness trainer that has experience dealing with pregnant women exercising, to help them get into a safe pregnant well woman exercise program, because some women will try to overdo it all through their pregnancy, and then it can cause problems. But it is safe generally for women to do some form of exercise throughout their whole course of pregnancy. Malignancies, if people have active malignancies in their body, there's certain things we can't do, like we wouldn't do a lot of stretching around that part of the body or strengthening around that part of the body, or using like hot packs or electrical modalities. We have to be careful with people with pacemakers, with modalities. People that have impaired sensation, so maybe after their injury, they can't feel things the way they used to do on that side, or it feels funny now. So if we're using modalities on them, like a hot pack, we might have to watch their skin every few minutes to make sure we're not burning them. And if people have decreased cognitive abilities, when we say cognitive, we mean thinking, decision making, being able to think rationally, logically, think for themselves, be of their own sound mind, for their age and maturity level. Sometimes we have to deal with that with different injuries and with different types of therapy, no matter what type of field, ortho or not. So we have to deal with that too. So sometimes there might be certain things that we would normally do with a patient that we might not be able to do, because our patient just can't understand why we want to do this, and it upsets them, and we can't seem to reason with them, and we can't seem to distract them and make them see it a different way. So we might have to just leave that part of that exercise or that modality out for that patient because of their cognitive capabilities. So we have to be adaptable. Thermotherapy is heat therapy. Helps with joint stiffness, helps with pain. We have ultrasound, diathermy, moist heat packs. Cryotherapy is cold therapy. Decreases cell metabolism. So you use cold therapy right when you have an injury or an illness or a surgery to decrease cellular metabolism and because that improves cellular survival rates. It decreases the inflammation coming to the area, decreases pain and muscle spasms, and promotes vasoconstriction. So if you do all that, it slows down the damage caused by the injury or the surgery, and will promote healing at the beginning of the healing. Then you would switch to heat later on, within like a week to 2 weeks later. Indications for cryotherapy would be acute injuries or chronic inflammatory injuries. So usually we always use cold for acute, and then for chronic we usually use heat. But if it's a chronic condition that has inflammation, we're still going to use cold. Sprains, muscle sprains, we're going to use cold. Swelling, edema, we're going to use cold. Spasms, we're going to use cold. And just any kind of musculoskeletal pain, we can use cold. Some people like cold, some people like hot. You know, in the chronic phases, it doesn't matter. But in the acute phases, you always want to use cold, because if you use a hot modality in like a hot pack in the acute phases, you can do more damage. Hydrotherapy. We did talk about hydrotherapy in the use of people with polio and people coming back from World War I and World War II with amputations. So we have aquatic therapy for ambulation activities and range of motion. But then we also have these old tanks up here that are for wound care. So people that have wounds on their bodies or full body burns, they have to be submersed in liquid and warm water to have that dead skin to soften so it can be removed. And so that's another type of hydrotherapy. That's true hydrotherapy if it's for wound care. If they're doing it for exercise, like this picture color is, that's usually called aquatic therapy. That's usually how the terms are used differently. Aquatic therapy can be done one-on-one or could be done with a group. It can be done skilled by one of us as a PT or a PTA. And then when we discharge them, maybe depending on the person's age, if they're an older adult and they maybe are at risk for falling, but we want them to keep exercising, we may tell them to go join an aquatics program class for seniors at the Y. They always have exercise programs at different gyms for seniors or back pain patients that they can get into after they're done with their therapy. And those are always very, very good for our older clients. People with multiple sclerosis do very well in the pool too. Electrotherapy is the use of electricity that we use sometimes with ortho patients and sometimes with neuro patients, but it's used for pain control, muscle spasm, and for getting an increase in muscle strength. So we'll talk about those next semester. Manual techniques. So don't look at this and think that we're going to be doing massaging, because don't let anybody ever look at you and say, oh, you're a PTA, you know how to do massages. We are not massage therapists. When people ask me if I can know how to do a massage, I get very offended. I did not go to massage therapy school. I went to physical therapy school. You are not going to massage therapy school. You are going to PTA school. You are going to be much higher skilled than a massage therapist. you know all about pathology. You're going to know all about musculoskeletal system, the brain, how physiology works, how we get people better. Massage therapists are just there to work out kinks and muscles and help you relax. No offense to anybody if you are a massage therapist, but you know, I like to let people know what the difference is. But manual therapy, you know, besides just stretching, we do some deep tissue work. So there are times we may do some of these different types of deep friction massages over scars to help break them up. We do a lot of massage over scars, like surgical scars, because if we don't, they'll tighten up and adhere to the skin, and it can cause a great reduction in range of motion, and it can be permanent for your life. So we do a lot of surgical scar massage, but we can do massage for muscle spasms and for relaxation, but generally we're not going to be doing massages and charging for that. That's really not ethical. Mobilization and manipulations are basically a type of joint movement where we are moving the joint, and it's not stretching the muscle or the ligament. I'm sorry, the muscle or the tendon. We're actually stretching the joint and the joint capsule itself. So there's not going to be a lot of, like, if you were stretching my elbow capsule, you would be mobilizing it here, and you would have, and I can't do it over video. There's just no way to do it over video right now over Zoom, but I would tell you to look up, I would highly suggest looking up, just go on YouTube and look up PT joint mobilizations or manipulations, and you can see what a mobilization looks like. We have traction, which is another kind of mechanical, which is a kind of spinal mobilization, but it's done by a mechanical machine. So that's when it will pull you either from the neck or from the lumbar, the pelvis, and separate your vertebrae column. I'm not talking, when I do this, I know that's exaggerating, but I'm talking like millimeters apart per each vertebrae. We do that for nerve impingements, muscle spasms, if the spine is just hypomobile, if it needs to be stretched out, if there's muscle inflammation. We can do it for joint pain in the back and for just regular joint pain, regular spine pain. We'll learn all about traction next semester. Gait training, we do this in just about every area of PT, but you'll do it in ortho too. So in ortho, you usually have weight bearing statuses. So let's start at the top, at the bottom, and go up. WBAT means weight bearing is tolerated. That means yes, and this is usually has to do with a leg, or it can be with an arm too. It means something happened, I had an injury or surgery, or something happened to this limb, but it's safe for me to walk on it, or it's safe for me to bear weight through this arm, to lean on it. It's safe for me to do anything I want to do with it within my pain tolerance. Okay, so that only the doctor will set that. Okay, partial weight bearing means, well, that doesn't really tell you a lot. That just means that I can't bear all my weight on one of my extremities. So maybe your doctor might give you what's called toe touch weight bearing, which means you can walk with your walker or your crutches, but on your bad leg, or your surgical leg, you can only place your toes on the floor for balance, but no weight through it. Or another kind might be foot flat weight bearing, where you can put your foot on the ground flat, but no weight through it. It's just for balance. And you're just using your walker or your crutch and your good leg and hopping along. And then non-weight bearing means you cannot bear any weight through that leg, or you're going to disrupt the healing process, or you're going to ruin the surgery that they just did. So that's walking with a walker, and hold, or crutches and holding your leg up, or being in a wheelchair with the leg rest, holding your leg up. The doctor is the only person that's ever able to address a weight-bearing status. We as PTs or PTAs are never able to decide if a patient is able to change or upgrade a weight-bearing status. The doctor is the only person that can do that. So they usually go by length of healing time, bone healing time, tendon or ligament or muscle healing time. But we definitely play a part in that healing time, because as they're in those weight-bearing statuses, we're still working with them just within the weight-bearing tolerance and the weight-bearing status. But our activities can help those things heal and get better quicker and get them back on their feet sooner than if we didn't do anything at all. Okay, an orthosis is a brace. So this is just an external device that helps provide support and stabilization. So you might have seen old types of braces before that were made out of metal and leather. Nowadays they're made out of mostly plastic, and this black one here is made out of carbon fiber. The carbon fiber ones and the plastic ones are extremely light and flexible and durable. This guy over here on the other picture, he's wearing a spinal orthosis. He must have had a spinal injury, and he's got to wear a temporary spinal jacket so that he doesn't rotate or bend his spine, or he'll have further injury. Prosthesis is an artificial limb, a substitute for an amputation. Probably knew that. Okay, so real quick, just to end, let's talk about a few pathologies. So we've got DJD, degenerative joint disease. Well, that is a type of arthritis, osteoarthritis, that is marked by progressive cartilage degeneration in the synovial joints and the vertebrae. It's basically just natural wear and tear of the joints and the cartilage over time. That's all degenerative joint disease or osteoarthritis is. It's normal. We're all going to have it to a degree at some point in my life. I am already getting it in my thumbs from texting so much. That probably shows my age, but shouldn't have said that. But osteoarthritis is just normal. We all are going to get it at some point in our life. The goals of what we should be doing for people when they come and see us for that, even though we can't reverse it, we help them learn to control their pain with modalities, which we'll learn, get rid of inflammation, and then we teach them how to do functional activities and strengthening to get better. And if they need any devices, we can help them with that too. Now, rheumatoid arthritis is also a type of arthritis, but this is an autoimmune disease. So this is one that you are going to be born with, or it may be something in the environment may trigger this, but it becomes an autoimmune disease where the disease attacks your joints. And so over time, it attacks the synovial membrane around your joint and your cartilage inside your joints. And this can be much more disabling for people. So the big things we're doing for this is just preventing the deformities as long as possible with splints and orthotics and bracing and managing their pain. Osteoporosis is a very common orthopedic condition that older adults get. It's basically just a decrease in the bone mass density. So not as much dense, their bones are not as dense they don't have the density of calcium as they once did. So older people are more predisposed to fractures, especially compression fractures of the spine. Compression fractures of the spine happen when a vertebral body is weak. If these are two vertebrae sitting on top of each other and one becomes weakened and it just kind of flattens, it just kind of collapses. Well, and that's what causes older people over time to tend to hunch over a lot, is compression fractures. Those that can't be reversed by compression fractures. Now, some of it's just bad posture, but some of it would be compression fractures. Osteoporosis also just leads to kyphosis, which is a forward curvature of the spine. Excuse me, guys. Had to sneeze. Kyphosis is, we do have a natural thoracic kyphosis, but if you have a extra kyphosis, it's a forward curvature of the spine. So with these people with osteoporosis, we want to just restore their mobility. So if they're not very mobile, we want to get them mobile again. Let's get them flexible. Let's get them stronger. There's a law that you may see on your test that's called Wolff's Law, W-O-L-F, like the animal. And Wolff's Law was named after the scientist that discovered it, that bones become more dense the more weight and activity they have put through them. So the more weight-bearing activities, the more walking, the more weights that are lifted, the more pushing, pulling, being more active in everyday life, even just doing housework every day, all day long. Even if you're a retired old lady and you don't have anything to do and you just do your housework all day, that's better activity than sitting in your chair and doing nothing and letting your bones waste away. So the more activity you do and the more active you remain, the more dense your bones are going to become, and the less risk you'll be for fractures. Osteoporosis is another big reason for hip fractures, and where people have to have hip replacements. Tendinitis is just an inflammation of a tendon, usually due from overuse of it or from poor posture. So tendon just means tendon. Itis is inflammation, usually from micro trauma, from poor overuse or poor posture. So we just help people with reducing their pain and correcting the muscular imbalances in their posture. Bursitis, a bursa, if you haven't had it in an A&P yet, is a small fluid-filled sac that goes over a bony prominence. So we have a bursa over our elbows, bursa over our patella. They're just little shock absorbers, little gel caps, or as you will. They're super duper thin. Sometimes those can become inflamed because of injury or overuse during, maybe if you are playing if you play a certain sport and you're used to a certain position or repetitive movement, you could get bursitis. It could be real sore. So you just, the way to get over that is ice the bursa, rest up, stop the repetitive motion, limit the motion, so stop the sport for a little while, or limit the amount of weight or activity or repetitions you're doing. Okay, a strain is an injury to a muscle. A sprain with a P is an injury to a ligament. Okay, those are always mixed up. So you sprain your ankle when you tear your ligaments of your ankle. You strain a muscle when you tear a muscle. When you, like, if you pull a hamstring muscle, that's a strain. That's an actual separating of the muscle fibers. A sprain is just an injury to a ligament. Like if you sprain your ankle, you didn't injure your muscles, you stretched the ligaments. But for either one of those, we do what we call price. This is rice, but now it's price. So we do protection. So we protect the area. We rest it. So we're going to get to an area where we can be safe and comfortable and not have to move it. We're going to ice it, compress it with ACE wrap or compressive bandage to prevent swelling, and elevate it to prevent swelling, because the more swelling we get, now a little bit of swelling is normal, but the more swelling you get around an injury, the longer it's going to take to heal. So the more pain it's going to cause. All that's going to help with the restoration of, then we're going to start getting, as the person has less pain, we're going to restore their range of motion. slowly with slow joint mobilizations and slow stretches, at the same time doing gentle strengthening and stretching, and lots of patient education on home exercise and what they can be doing on their own. So before we end this, a lot of these things that I said, as far as these last things, restoring range of motion, strengthening and stretching, modalities, and patient education, that's pretty much what we do with all of our patients. I went through a lot of ortho-specific stuff with y'all today, but in the other chapters we'll go through, you'll see more things related to those. But history taking is the same in every area. You just take a little bit more history related to that pathology, if that makes sense. And then you make your goals a little bit more related to those functions that were lost. So you'll say orthopedic type functions are going to be different. Orthopedic impairments are going to be different than neurologic impairments are going to be different than cardiovascular impairments. So you'll see all those. Okay. Thank you very much. Send me emails if you have questions.